Good afternoon, everybody. It's a real pleasure to introduce this webinar that will be held by my good friend and colleague, Mattia Severi. And the focus of Mattia's presentation will be on SPAL technique, as you may possibly know, which is a novel, simplified technique that aims to augment the peri-implant bond, particularly when it's deficient on the buccal surface of the implant that has been placed. I'm Leonardo Trombelli. I'm the one that firstly proposed the technique that was published in 2018, and we have gathered so far at least a decade of experience on this procedure in different clinical conditions and using different biomaterials. But the real man, the real character that will, illustrate all the principles and the tricks of the procedure will be Mattia Severi. Mattia Severi developed the procedure with me over the last 5 to 6 years, is author of several papers focused on the procedure, but last but not least, is a very talented clinician. So what I have asked to Mattia is to try to define how we can solve this type of clinical condition, meaning the situation in which we are lacking of the buccal bone plate at the time of implant placement. And one of the ways, it's not the only way, but one of the way will be the subperiosteal peri-implant augmented layer. During the presentation, I will ask Mattia several questions. The first one is, why should we treat the peri-implant bone dehiscence? Is there any reason for that? The second, then, how can we correct the peri-implant bone dehiscence? But particularly when we are dealing with SPAL technique, what are the biological principles that rule that specific procedure? And last but not least, which are the relevant factors that we have to carefully consider for being successful? So Mattia, let's start with the first question, which is why should we treat a peri-implant bone dehiscence?
Hello to everybody, and thanks, Professor Trombelli, for the kind introduction. It's really exaggerating. I'm just a former PhD study student who was involved in developing this technique and was passionate in developing it. So let's start. So why do we have to treat a peri-implant bone dehiscence? But first of all, because from a clinical point of view, when we leave a peri-implant bone dehiscence for spontaneous healing, we observe a higher peri-implant bone remodeling at the RX, whereas when we correct it, we observe a bone gain. So the first aspect is, if we left adhesions for spontaneous healing, we're going to lose interproximal bone. Moreover, the more peri-implant bone dehiscence site increase, the more we will assist to the developing of peri-implantitis. So you can see in this previous study that when no residual in the group where no residual bone dehiscence was present, only one of 8 implants was affected by peri-implantitis. Whereas when we have 1 or 2 or more than 1 millimeter residual dehiscence, the incidence of peri-implantitis was increasing. Finally, we can see that in this animal study, where implants were intentionally placed completely surrounded by bone or with experimentally induced creative dehiscence, radiographical bone levels were substantially better or comparable in both type of experimental model when regular plaque removal was performed. but instead, a greater bone loss, a far greater bone loss was observed in implant presenting a peri-implant bone deletion set placement when free plaque accumulation was performed. Therefore, we have to know that in ideal condition, maybe the persistence of peri-implant bone deletions may not be a clinical problem, but in the real world, in every professional setting that we have, when a patient are not performant in removing plaque or whatsoever, we know that we may have detrimental conditions and detrimental absorption of the interproximal bone when plaque accumulation is allowed. All this information are gathered in this clinical guidelines that was published recently that states that we have to do whatever it takes to ensure adequate thickness of the peri-implant bone at the time of implant placement in order to allow the peri-implant tissue to remain in a healthy condition over time. In other words, yeah, we have to move from this condition where peri-implant bone deletions are observed to this condition when at uncovering, peri-implant bone deletions are completely corrected. So, how we can correct a peri-implant bone deletions? The gold standard, my friends, is still guided bone regeneration. So the combination of bone graft material with a collagen or an unresorbable membrane. In this case, we can see an implant placed, presenting both adhesions and the fenestration and placement, the stabilization of a resorbable membrane, the correction of the defect using a combination of xenograft-derived, bovine-derived xenograft and autogenous bone, its coverage with a resorbable membrane, and we can see at the 6-month uncovering, the adhesions was completely corrected, and the same finding we can observe in the 3D examination that was performed for other reason, for placing implants in the third sextant. But so this concept was well explained in this systematic review that we performed some years ago, where it was clear that the combination of bone graft material with a resorbable or non-resorbable membrane was among the best treatment to obtain the complete correction of peri-implant bone deletions. However, in this systematic review, there was another technique that was included. There was the combination of patient-owned periosteum with a bone graft that actually was the SPAL technique. And as you can see, don't look at the numbers since they represent a statistical parameter that is not of our interest right now, but we can see that among GBR, SPAL technique was among the best treatment to achieve a complete deletions correction. So let's move to how SPAL technique works. As you can see in this brief video, SPAL is mainly based on the partial thickness dissection of the gingiva lining and edentulous ridge. You can see that using a 15C blade, the partial thickness flap is elevated, thus the lining an external layer, namely mucosal layer. And then the periosteum is elevated using angulated tunneling knives in order to create a pouch. You can see now implant with adhesions. You can see that the pouch is filled with the bovine-derived xenograft in order to completely correct the peri-implant bone deficiencies and to increase the peri-implant backbone thickness. Periosteum is then stabilized to the lingual flap using internal metrial suture in 6-saw resorbable sutures in order to stabilize the graft material and allow for the condition for obtaining a Hun stability. I'm sorry. So you can see the periosteal layer stabilized, and then the mucosal layer is coronally advanced to close the wound. And you can see that 4 months after implant placement, the deficiencies are completely corrected and an adequate thickness of peri-implant bacanal tissue is present. So let's explore step by step the technique. This is the classical clinical condition when we perform SPAL technique. That is actually an edentulous posterior mandible. So we will use this cartoon in order to explain every phase of the technique. So you can see we start with a crestal incision continual vertical on the mesial tooth. Then the buccal gingiva is dissected taking care in leaving the periosteum underlining the bony crest, and that is the clinical image showing us the partial thickened incision, the vertical incision, and the periosteum lining the bone crest after the partial thickened dissection. Subsequently, a second incision is performed in order to separate the periosteum from the bony crest, and the periosteum is then elevated using tunneling knives with various angulated edges, thus creating a pouch that will accommodate the graft material. And we can see the clinical example of what we have already seen, the periosteal pouch completely elevated from the bone crest, and as you can notice, there are no ulcerations and no interaction of the continuity of the periosteal layer. Subsequently, implant sites are prepared, and before placing implants, cortical perforation are performed. We perform it before implant placement in order not to touch the implant surface. Implant are placed. We usually employ soft tissue level implants with 1 millimeter polish collar that is placed equicrestal, as you can see in this demonstration. Then the ischiases are corrected with a graft. In this case, a combination of autogenous bone and bovine derived xenograft, but you can use completely bovine derived xenograft without any clinical difference. And then you can see periosteal layer is sutured to the lingual flap using internal mattress suture in order to both stabilize the graft material and coronally advance the lingual flap that will contribute to the primary intention closure. And this cross-section, you can see what we have at the end of the suture of the periosteal layer. We have the implant in place, we have the polish collar at the level of the bony crest, the graft completely correcting the peri-implant bone adhesions and increasing the thickness of the peri-implant buccal tissue and the periosteum stabilized. Please stop the microphone if someone of you have the microphone open. So this is the clinical evidence. An implant presenting a peri-implant bone deficiencies, cortical perforations, a graft composed completely by bovine-derived xenograft and the periosteum stabilized to the lingual flap, and you can appreciate how the lingual flap is already coronally advanced before starting the final part of the suture phase. And then you can see the end of the procedure where the vertical incision is closed with single interrupted sutures, whereas the mucosal layer is coronally advanced using internal mattress sutures in order to stabilize the flap and make the connective tissues of the two flap to touch them, and the incision line that is finally closed with single interrupted sutures. And in this cross-section, we can see what is happened at the end of the surgical phase. And at this 6 months placement, you can see that peri-implant bone deficiencies were completely corrected. An adequate, that means at least 2 millimeters of peri-implant bone tissue thickness was present. And soft tissue that you're seeing is due to the fact that when we perform the uncovering procedure, we open a partial thickness flap in order to manipulate the soft tissues. But, you now have seen some clinical images, but why do we actually imagine that this technique would work? Why did we decide to try to reconstruct peri-implant bone without employing a membrane? But because there are several biological reasons. The first is that periosteum anatomy itself is constructed in an osteoinductive manner. Periosteum is constructed by 2 layers, a fibrous layer that actually give the mechanical structure, the mechanical resistance of the periosteum, and an internal layer that is called the cambium. And in this funny image, you can see the cambium restaurant in Italy, since cambium layer has the role of giving cell, and it contains local growth factors, it contains blood vessels, and it contains osteoinductive cells. So the cambium layer has the role of nourishing the bone, as well cambium restaurant has the role of nourishing the human. And if you look at this study, where the femur of the dog was actually separated and the fracture was stabilized, they constructed a model where one group of dogs underwent spontaneous healing, having the two sections of the fibula completely separated. In the other group, the missing fragment was completely covered with periosteum. And let's see what happened. In the spontaneous healing group, no bone formation was observed 20 weeks after the stabilization of the fracture. Whereas, look at this RX. Where the fracture was covered by the femoral periosteum, we can observe an almost complete filling of the missing part of the fibula. Moreover, periosteum is a highly vascularized tissue and has the potential, as you can see in this study, to reconstruct the vascular blood supply from periosteum to the bone in 7 days. So, if we imagine the experimental model of our technique, we know that when we suture the flap, we stabilize the periosteal layer, periosteum will reconstruct its vascular chain, vascular network with the underlying bone in very few days. In this study, really interesting study, the authors tried to evaluate the role of the periosteum in supracrestal bone formation by doing a split half study. So, in one group of implant was placed in the calvaria of the pig and was left for spontaneous healing, covered by a full thickness flap. That means that was covered with periosteum only. In the right side of the image, implants were exfoliated using a polydioxanium capsule that had the function of excluding the periosteum from the healing phase. And look at this histology. When periosteum was involved in the healing phase, a complete bone reconstruction was observed. Whereas, when periosteum was excluded, no supracortical bone formation was observed around the implant. But if you look at the space between the periosteum placed above and the polydioxanium capsule, we can observe a novel bone formation, thus indicating that when periosteum is included in the healing phase, it has a paramount role in inducing new bone formation. Last but not least, cortical perforation have an important role in our technique in forming new bone, since you can see that in this model, where a technique similar to ours was performed, in other words, periosteal destruction was performed in association or not in association with cortical perforations, we can see that the area of new bone formation and the bone density were significantly higher when periosteal destruction was associated with cortical perforation with respect to periosteal destruction alone. Putting together all these informations, we can see that our technique perfectly respects the PAS principle. PAS principle is of paramount importance for bone regeneration that encompasses primary wound coverage, and we actually obtain it by coronally advancing the mucosal flap and primary closing the surgical wound. Angiogenesis, but as I showed you before, angiogenesis is provided both by the periosteum and by cortical perforation. The creation of a secluded space, and that is given out by the filling of the space between the periosteal layer and the bony crest with a stable, non-resorbable bovine-derived xenograft that allows us to maintain a space during the healing phase. And finally, by wound stability, that is actually obtained by both stabilizing the periosteum to the lingual flap and obtaining a tension-free primary intention closure, coronally advancing the mucosal layer. So, all this information together led us to the histological evaluation of the tissue that we reconstructed after SPAL technique. And we can proudly say that 10 years after the first case, SPAL is actually able to induce new bone formation, as you can see in this sample retrieved from a case performed with particulate xenograft only, where you can actually see the native bone in direct contact with the biomaterial that is completely embedded in bone of new lamellar bone. So all the principles and all the biological rationales that we put together 10 years ago actually reverberates in this result. So we are not only able to reconstruct some amorph hard tissue around the implant, but we are actually able to reconstruct new vital bone. And so that, which are the, let's move to some technical aspects, to some technical evaluation we have to take into account before performing the technique. And let's describe them using a paradigmatic case. This is the classical condition where the technique has to be performed. You see a posterior mandible, a heavily resorbed ridge, and an horizontal deficiency, but with a vertical bone height allowing us for the placement of an implant. We perform the incision that is conducted partial thickness both on the crest then on the mesial side of the mesial tooth, and take care of elevating a mucosal layer without perforating the mucosal layer itself and not lacerating the periosteum. Periosteum then is elevated, and you see I'm using the tunneling knife as parallel as I can to the bony crest in order not to perforate the periosteum or to slaughter it on the convexity of the mesial tooth. So you can see that the integrity of the periosteal layer is of paramount importance in order to obtain the clinical result. The implant site is prepared, and as I told you before, we perform the cortical perforation before placing the implant in order to be free to invade the bone medulla without the risk of touching the implant or without the need for doing perforation far from the implant site. And we, as I told you before, we use tissue level implants that have 1 millimeter polish color, but you have to have the trick of placing the most coronal part of the polish collar at the equicrestal level in order to facilitate the primary intention closure, in order to have the rough surface of the implant completely contained in the periosteal pouch. Then you can see the periosteal pouch is grafted, and the graft has to go coronally, at least correcting, including even the polish collar. We have to overcorrect both in height and in thickness. And then you can see the periosteal, the internal matrix suture that runs around the implant and stabilize the periosteal layer in its most coronal position in order to compress the graft where we want to maintain it. And if we have performed every step as we have to perform them, the primary intention closure is obtained. And in fact, the X-ray is what we want to see at the end of the intervention. We obtain a complete primary intention closure at 2 weeks. And at 6 months, when we are ready for implant uncovering, we can see that the profile is completely different. We moved from a concavity to a convexity, so we already know that our implant will be completely covered by new hard tissue. In order to correct the mucogingival deformity that always happens after a bone reconstructive procedure when we conradly advance the flap, we perform a free gingival graft in order to reconstruct the peri-implant keratinized mucosa. And as you can see by the position of the graft, what the tissue around the implant is hard tissue, since is able to, as you know, adapt the free gingival graft above its profile. And so we move on to the provisional restoration delivery, and finally at the final restoration delivery. So we started from a bone deficiency, and we arrived at the delivery of the final restoration, having reconstructed both hard and soft tissue peri-implant tissues in a really simple manner, in a user-friendly manner, using only biomaterial, minimizing the cost. And the concept we want to transmit is that this is not only a surgical technique, but this is moreover a way of thinking. You know, when you have to manage an atrophic posterior, an horizontally atrophic posterior mandible, you can start by default with this kind of flap. So you will be ready to correct a peri-implant dentition, either that you have diagnosed this on a 3D exam, or when you face a peri-implant bone dentition when, for some reasons, the CBCT exam wasn't precise in previsualizing it. This is the RX at the time of final restoration delivery. You can see the bone levels are adequate, and the implant is completely surrounded, at least to the examination, by new bone. So all this stuff that I've shown you in this presentation are condensed in this series of publications we performed over the last 7 years, but we started to perform the technique much earlier than that. We started in 2015. We want to be sure that the technique works before starting publishing about it. And overall, we can finally say that SPAL technique is a user-friendly, simplified, cost-effective, biological-driven procedure in order to horizontally augment bone around implants. Thank you very much. Sorry. Thank you very much for your attention.
Thank you, Mattia. That was a very nice explanation. I guess that you cover all the biological principle and also the surgical tricks that may lead to a successful procedure. So I guess that now it's time to have questions from the public. If there is any questions, Mattia will be more than pleased to take it.
Okay, if you want to turn on your microphones, we will be happy to answer all your questions.
Is there any question from the audience, or?
How much horizontal defect can be managed in a atrophic posterior mandible? You know, you have anatomical limitations that is the bone profile of the adjacent teeth. So, you know, you can augment, but you cannot augment more than the ideal line connecting all the convexity of the tooth or the previously present tooth. But if you place the implant in a correct prosthetic position, you will have enough space to increase the thickness of the peri-implant bone tissue, hard tissue, in order to correct the adhesion and have an implant in prosthetically correct position.
I guess, Mattia, the question refers to how much you may augment.
In terms of millimeters?
No, I mean, I tend to believe that it's the limitation between a one-stage and two-stage procedure. Maybe.
Oh, okay. So, you know, in this case, you have to take into account the initial thickness of the edentulous bony crest, since you have to respect two principles. The first is that you have to stabilize an implant in a correct prosthetic position. but you even have to have at least 2 millimeters of lingual bone where you can stabilize the implant in order to prevent the resorption of the lingual bone. So a two-stage procedure, so a previous reconstruction and subsequent implant placement has to be taken into account if you do not have these two features together. So I am able to stabilize the implant, and I am able to stabilize the implant in prosthetic position, leaving at least 2 millimeters of lingual bone. We have no data actually in, thank you for detailed specifics. We have no data on how much we can augment in a pre-implant procedure, since this technique was thought and performed in order to correct peri-implant bone dehiscesis at time of implant placement.
Yes, we have maybe we have some suggestion by Steigman, right?
Yeah, yeah. If you want to look at a similar technique that was performed in order to increase the thickness of an edentulous crest using periosteum, you can refer to the article by Steigman, 2012, I think, or 2015, but if you give me your email, I can send it to you, where he combined the use of a periosteal pouch and the collagen membrane in order to increase the thickness of a bony crest prior to implant placement.
Is there any question? Don't be shy.
She's from Malaysia. Oh, hope to be able to you. So as yourself here around. Hi, Othgur. Yes, we actually elevate.
Why don't you read the question? Because the other one.
So Dr. Othgur asks if we elevate the lingual flap in some of our cases. We actually elevate it, Othgur, in every of our cases, since we actually separate the lingual flap from the bony crest, dissecting the fibers of the mylohyoid muscles in order to have the possibility of coronally advancing the flap. This has two advantages. It dramatically increased the rate of primary intention closure, and it allows us to stabilize the periosteal layer. So Dr. Ordu asked us if we use only bovine derived xenograft. Actually, yes. The histological data that you see is from samples harvested from cases where we used bovine derived xenograft only, and all our publications are mainly related on particulate bovine derived xenograft. So you can use it alone.
Any more questions?
Is there any specific instrument necessary for the technique? But, you know, you surely need a thin blade, like a 15C blade, a Castro Viejo needle holder in order to use 6/0 sutures, and any microsurgical elevator that will be needed to elevate the periosteal layer. We actually use the Allen tunneling knives. We use all three of them. They have various angulated sharp edges. You can use a microsurgical elevator like the P-Trom. It is mutuating from the periodontal regenerative surgery, but that's the most.
All right.
Thank you. So, if you do not have any more questions, we kindly thank you for being here, for listening to us in this really warm afternoon.
Yeah.
And
It's been a great pleasure. And I guess please keep on following the Instagram page on SPAL Technique, because more things will happen during the next weeks. And so you will take the opportunity to have more things. And particularly, we would like to have the possibility to share clinical material. And if you have cases or questions related to cases to share with us, please feel free to do it. So, having said
Sorry.
that,
only this case has been a game changer in my practice. And
Yeah.
I mostly use bone level type implants, and also I have a better result with longer healing caps or covers. Oh, thank you for the addition, also.
it's a real game changer.
It's really
we agree.
sense.
We agree on that. Okay.
Okay. Thank you very much
Thank
to
you.
everyone.
Thank you. Thank you very
Bye-bye.
much.